Welcome to Fuzzybutts and Friends. Well, even though it drives Fuzzybutts absolutely nuts all over this place, I'm your host of this show, your big dog, Luke Robinson, and I'm happy to have back again this week our co-host and occasional co-pilot, Ginger Morgan. She's the executive director of the Puppy Up Foundation. Ginger, how are you this week?
I'm doing well. I'm really interested in what our guests have to say this week.
I am too. This is all about pet and canine oncology. We were just talking with our guest today about how diverse our cast of characters have been on Fuzzybutts and Friends. But we always like to go back to our roots and talk about canine and companion animal cancer. But before we begin, I want to remind everybody, our audience, that Fuzzybutts and Friends is available every Tuesday on our YouTube channel. That's fuzzybutstudios.com.org. And our podcast is also listed on, I think, most of the podcast channels now, platforms. I think we're missing a few, but you can find it on Spotify and iHeartRadio. We have it out every week, but about 3 months from now, I'll be on Walk 3. And even though I'll be in the tent, we're going to have Fuzzybutts and Friends on every Tuesday. Don't you worry. Now, before I introduce our guest this episode, Ginger, as you know, my second Fuzzybutt, Murphy, who walked alongside me with Hudson on my first walk from Austin to Boston, just after we got into Boston, he was diagnosed with nasal adenocarcinoma. And we went out to Colorado State University. We did a radiation treatment, IMRT, over a 28-day period. And we went through the whole process. And then that failed. So we went through the SRT. And so we know a little bit about the topic, today's topic on this episode. And it's been 10 years since Murphy went through his treatment. So there have been a ton of advancements. So I'm very, very glad to have on this episode of Fuzzybutts and Friends, the Chief Medical Officer of PetCure Oncology, Neal Mauldin. Neal, how are you, sir?
I'm doing really well. Thanks.
Excellent. We also have with us, and I'm delighted to say, he's the biz dev guy with PetCure, Ben Chiswick. Ben, how are you, sir?
I'm doing great. Thanks so much for having us.
Good. I meant no disrespect. I'm a businessman myself, and you provide a very important piece of this conversation. So I'm very glad to have you with us today as well. So let's really dive right into this because we want to keep this tight to an hour, and we have a lot to cover. So Neal, I want to start this conversation with talking about cancer in companion animals. You've been practicing for a while now. So what are you seeing out there?
Well, I think the biggest change is our ability to diagnose and to diagnose earlier. I think that when I was a resident a few years ago, I got told that being an oncologic specialist wasn't really a very wise career choice because people weren't going to treat their dogs and cats and ferrets for cancer, and that I should probably do something else. Right now, today, our biggest challenge across the industry is just providing access. Medical oncologist, radiation oncologist, it doesn't really matter what stripe it is. Their services are so in demand that quite frequently there are multiple weeks delay in getting in to get a consult. So I'd say, I don't really think we're seeing more cancer per se. I think we're diagnosing more because people are choosing to take that path. Families are choosing to take the same path you did with your guy. The far and away, the biggest challenge to us is really providing the access that the families are looking for and need.
Access, absolutely. You couldn't said it more perfectly. Interestingly enough, I find it very fascinating, the person who advised you not to go in radiation oncology, because that person couldn't have been more incorrect. I'm sure, as Ben would attest to, if you look at the amount of money that pet parents are spending every year on care for their companion animals is trending on considerably upwards. And that makes sense because we are valuing our companion animals much more highly in society. So So focus on that. So I guess so we kind of have a basic understanding of treating cancer, and we know that, Dr. Mauldin, we know that, and we also know that there are more uh, there are more dogs that are being diagnosed every year with cancer. I think the last statistic I think that Ginger and I read was 6 million. They believe that there are 6 million new cases of cancer in dogs every year. So before we start this conversation about the technology, the wonderful technology that PetCure Oncology is delivering to the marketplace, talk to us about the three different treatment modalities of cancer.
Well, the three traditional pillars of cancer therapy have always been surgery, radiation, and then medical oncology, chemotherapy. And surgery and radiation oncology really share the same goal. Our treatments are primarily designed to control a local tumor, a local disease like perhaps a nasal tumor. Whereas chemotherapy tends to be for whole body cancers. And surgery and radiation are fairly interchangeable these days from a case perspective. A patient that could, perhaps warrant or would benefit from surgery, but either can't have it because of location or because of the family's feelings about the nature of surgery, perhaps it needs to be performed, then those are radiation therapy patients, and vice versa. I still think going back many years ago, one of my mentors told me the best treatment for cancer is to be able to put the tumor in one room and your patient in another. So I think most people still feel very strongly that surgical removal of a tumor is always best if you can achieve a complete removal.
Absolutely. On that note right there, when I took Murphy out to CSU, Steve Withrow took a look at Murphy and in the CT scan, and he would cut into anything, but he took one look at the CT scan and said, absolutely not. I can't discern or distinguish between inflammation and tumor tissue, so we're doing radiation. And Dr. LaRue was so wonderful there at CSU. So you're right, and that's kind of the nut of what I want to get to. Dr. Mauldin, is why would the pet parent choose radiation over, say, surgical excision or chemotherapy? Walk us through that decision-making process for the pet parent, please.
Well, it really boils down to two big things why people make the choice they do. One is just that surgery is not possible. Steve is the original oncologic surgeon in veterinary medicine. And as you say, he was not scared of anything. So if he said, I can't touch this with a scalpel blade, we were probably wise to listen to that counsel. So the first reason is just that surgery is not possible. That we have no surgical path. And reconstructive surgery is a fine path to head down as long as at the end of that reconstruction, you've achieved your goal of completely removing the tumor. If you can't do that, then a surgery with a big cost to the patient becomes a lot less attractive. And that's really the second reason, is that sometimes when you tell families what needs to be done, it's a tumor involving multiple ribs, we're going to have to remove those and reconstruct the chest wall, then they may not feel that that is an appropriate path, and we expect our families, or we ask of our families, that they be the advocate for their family member. And so a lot of times it's that, well, the surgery is possible, but the family doesn't want to head down that path. And so in that setting, again, there's pros and cons to both things. If you completely remove a tumor surgically, then it's gone and the tumor really doesn't get a vote. On the radiation therapy side of things, we can treat a tumor in place. We're not causing any tissue destruction, except especially with newer technology, to the tumor. But as long as the tumor's in your patient, it gets a vote. So just because you decide to treat something with radiation doesn't mean that it will elect to respond.
That's absolutely correct. And you couldn't have put that more precisely or put a finer point on it with Murphy, because, you're right in that. And that was probably a good thing that we didn't operate and try to take the tumor out or as much tumor tissue out of Murphy, but we didn't get a good outcome in the end because I chose IMRT. And that failed. Not only did it fail, we had a secondary tumor that occurred after 4 months. And then I did SRT. So in my assessment of that, I should have done SRT first. And so for our pet parents, let's break down those protocols and explain what those mean, because those distinctions can mean the difference, Neal, as you know, between a good outcome and a not so good outcome, correct?
Yep. Well, when we think about the world of radiation therapy, we really break the protocols into, I guess, three big buckets right now. Bucket one is palliative radiation, where tends to be relatively low tech and, really more point and shoot radiation. And, we need to keep in mind what the word palliative means. That is a radiation protocol that is designed to improve quality of life. So if you have a patient with a lot of bone pain, say, we would use palliative radiation to try to get them some relief. But our expectation of long-term control is really not very high with that kind of radiation. The other, I guess, big bucket is definitive or curative intent radiation. And as you said, you've had experience with both now. The first one of those types of protocols is IMRT, or what we would call conventionally fractionated radiation. And that is, in the old days, we couldn't target very well. We couldn't deliver the radiation exactly where we wanted it to go. So the way we overcame that is we opened up our fields, treated a lot bigger area to be sure we got the tumor in there. But in the world of radiation therapy, as the volume of normal tissue that's getting radiation goes up, the side effects also go up. So the IMRT protocols tend to have a lot more side effects associated with them. And there's a lot more anesthetic events. The way to mitigate those side effects was to break the radiation treatment down into a lot of small treatments over time. Most old school radiation protocols are 19 to 21 fractions delivered over 3 to 6 weeks, somewhere in that ballpark. And when stereotactic became a thing, and I guess I've been doing stereotactic for a little bit over a decade now. It really was driven by advances in technology, where we can really precisely define our target volume. We can really precisely push radiation into that. So that allowed us to do two things. It allowed us to substantially decrease the size of the treatment field. And in that setting, as I said, as the normal tissue volume goes up, the side effects go up, and the converse is true. If you are treating with just a 1 to 2 millimeter margin of normal tissue, then the side effects are profoundly less than what you're going to see with an old school conventionally fractionated protocol. The other thing is, because we could target the tumor so precisely, we can push that dose a lot more aggressively. So most stereotactic protocols are in 1 or 3 fractions given on consecutive days. And getting back to that access point, that made a huge difference for a lot of families that didn't live next to a radiation therapy facility. In the old days, if it's like, well, you got to take 6 weeks, you either got to give us your dog for 6 weeks, or you got to take 6 weeks off and be here. It just wasn't a reasonable or feasible proposition for a lot of families. Now we can go from point A to point B in a week and get you, worked up, diagnosed, get treated, and back on the road home, wherever that is.
As I go back and reflect on the decision criteria that I used to determine whether I chose IMRT, SRT. Fortunately, I just finished my first walk, and I was mobile, and I was able to find a place to stay out in Fort Collins. So time wasn't an issue. But for me, the biggest thing is tissue damage to Murphy. and I was scared as hell of the primary for him, the primary side effect, which is burning of the snout, which I'm not sure if you can see that picture right there, but you can clearly see that, and that's after IMRT. So that's 28 days or 5 days times four, I guess 20 treatments or 25, I can't recall. But even with that, it did that amount of damage. So I was very concerned that SRT was just going to blow out, completely just decimate his whole area. And so that was, I think that the side effects was my primary decision reason. But is that the reason why? So I want to segue from that into PetCure Oncology, that you guys specifically focus on SRT, stereotactic radiation therapy, right? You guys do not do IMRT, correct?
No, we do all three.
Oh,
all
is that
three
right?
types. Yep.
Okay.
So, I would say the vast majority of our patients are treated with stereotactic protocols these days. But there are some patients where even doing a stereotactic protocol carries some risk. So if you have a really large surgical field, probably the classic example would be cats get a kind of tumor called vaccine-associated sarcoma. And those surgeries are usually quite extensive, and you'll have this huge scar. So in that setting, you don't really have, the treatment field is so large that you probably won't get away with SRS in those patients. Some families are just more comfortable with old school. We've been doing IMRT, or conventionally fractionated radiation, for 50 years in veterinary medicine, and on the SRS side, it's only 10 years. So some people aren't as comfortable with that. But really, when we talk to our families about their biggest concerns from a radiation therapy perspective, most of the time, the answer they give us is the number of anesthetic events required. That seems to be what scares families almost more than anything else. Side effects, yeah, okay, we'll deal with those. But you want to take my 14-year-old old timer that's got a brain tumor, and you want to anesthetize him for the next 20 days. That is something that gives a lot of families pause, for sure.
So is that why you're primarily known for SRT? Because I guess that was my misunderstanding. Is I know I had one of the, I think it was VCS, the oncology conference, every year. I have met with some people from PetCure. It was my understanding that you guys did SRT. So then that's probably your number one treatment then protocol.
Yeah.
Is for all those
Right.
reasons why pet parents just prefer SRT over IMRT. That makes sense.
Yeah, and I think the market has had a say in the direction we've moved. But also, in the early days, probably the thing we fought the most was just a lack of data, and a lot of concern over that. As the SRS and SRT and veterinary patients has really matured, there are lots of papers out there, not just coming from PetCure, but from CSU, has been a leader in radiation therapy for a very long time. That are showing that results we're seeing are equivalent to or better than what we could establish with IMRT. So in that setting, it kind of becomes a bit of a no-brainer for most families. It's like, well, we think the outcome is the same. We're going to do 1 or 3 anesthetic events instead of 20, and we're going to be done in a day or 3 days, not a month. And once you factor all that in, SRS becomes a pretty logical choice for a lot of families. There are some tumors that SRS is not appropriate, but again, that's our job, is to help you navigate all of the same navigation path you went through with CSU. We do all the time, trying to help people decide what the right course for them is.
Right. Well, I know you have a limited number of locations, or there's just a limited number of places that pet parents can get radiation oncology in this country. So the market bears out and sorts all that out for sure, that SRT would it be the more preferable protocol. But that certainly does dovetail us into the next question I have, and the next thing I want to discuss is the CT scan and imaging. So is it correct to say that you were saying that SRT is more precise than IMRT and from an imaging standpoint?
These days, probably not. The
Okay.
imaging capabilities of both are probably the same.
All right.
If you have a machine, that has a cone beam CT on it, and that you can really do finely delivered IMRT, then you're gonna use that exact same technology for SRT. I'd say more of the limiting factor in the veterinary world was the ability to actually offer SRT or IMRT, just because of the technology that your particular machine might have. Veterinarians tend to be great scavengers, and we have lots of machines out there that we picked up from hospitals that were getting rid of them, and okay, that's fine. It's great for point and shoot radiation, but it's not great for trying to do SRS or IMRT.
So just to clarify for the pet parents listening, that the locations that they can go to PetCure Oncology, you guys are a full service shop. They can anything in terms of radiation oncology, they can get at PetCure Oncology, correct?
Correct.
Excellent to know.
Actually, Luke, if I could interject, I would
Sure,
add to
please.
that. So as Neal mentioned, we'll do all modalities in radiation oncology. And in 7 of our 8 centers, we're also located inside of multi-specialty hospitals where, part of the strategy behind that, the model behind that is so that we also have medical oncologists down the hall, neurologists, surgeons, internists. So I would say the scope even goes just beyond radiation oncology in terms of educating the pet family and helping them understand what their options are. And ultimately, it is about making sure that they know all of those options across services and across modalities so that they can make the best decision for their pet family.
Yeah, no, it's a great time to talk about this, Ben. So, because I want you to walk us through the process, because the pet parents are going to want to know, hey, my dog is symptomatic of cancer. I need to go in to see my GP and I get the referral to. Just walk us through the process, how they can get to PetCure Oncology.
Sure. Well, I'll tell you exactly what I tell my friends when they reach out to me and say, hey, my dog, or hey, my friend's dog, right? I tell them to call 833 Pet Hero. And that's the place where it all starts. That's when my dog had a lump a couple of years ago. I called 833 Pet Hero. And that's our contact center. We're staffed with pet advocates who work all day, every day, helping guide people through exactly the process that you're asking about right now. So we'll get calls from, oh my gosh, I feel a lump on my dog. What is it? To, I just walked out of my medical oncology appointment and my dog has a diagnosis of X, Y, or Z, right? So it's really about first, what our team does is first identify where that pet owner is in the process and then kind of help guide them through the next step. So based on where they are and what they know, it may be setting them up with a medical oncologist near them or an imaging center near them to get some blood work done, to get some scans done, to identify, is there even a cancer? And then, the nature of that cancer. Or it may be for folks that are farther along that they've already got the diagnosis and they've already got a CT scan. And it's a matter of, getting that into the hands of Neal or one of his doctors to make recommendations on next steps. So there's one of the things we found very early on, frankly, was that there's such a void in information out there that question is really what we got most often is, what do I do, right? So we've tried, really hard to build out kind of a digital infrastructure through our website and through the contact center where when folks put that question into Google, they find something helpful and useful resources and hopefully find our team that can help guide them through those questions. That's
good to know, Ben, because one of the things that irritates me to no end is the time of the process, the length of the process, as certainly Neal can attest to perfectly, that At the moment that the dog becomes symptomatic, the cancer is already pretty well advanced, and you got to get him in, you got to get it diagnosed, and you got to get it treated ASAP. So for me, the shortest distance between symptom and treatment is where we need to be. So Ben, if PetCure Oncology or you guys can streamline that and have like a full service thing, full service shop, that's wonderful with your location for pet parents, because the longer it takes to get referral after referral, it adds more and more time. So that's the how, Ben, how pet parents can, once they get the lump, or once they have the concern, how. Now we need to get to the why. So Dr. Mauldin, let's talk about the indications. Give us sort of the main tumors, or sort of the main cancer types that pet parents would choose radiation over other treatments. I can't hear audio. Can you guys hear?
No,
All right.
I muted because my dogs were.
Oh,
announcing
right.
that there was
I could
somebody
do that
outside.
as well.
You know, there are a few bread and butter tumors, I guess you could say, you know, the things that really make up the core of what we do. One of those is nasal tumors, for sure. You know, there's not a lot of other options for treating a dog with nasal disease. And as you say, once we get to the point of having nosebleeds or a discharge, or maybe even a facial deformity, we probably have an advanced tumor that we have to deal with. The other would be brain tumors. Far and away are a radiation therapy problem in veterinary medicine. And, you know, from that, any older dog, you know, 6, 7 years old, that has what we call late onset seizures, probably has a brain tumor until proven otherwise. So, you know, if you have a perfectly healthy lab, or a perfectly healthy French bulldog, and at age 8 they have their first seizure, then we need to start looking for the brain tumor. Some other tumors that we would treat, osteosarcoma, so primary bone tumors. We treat a lot of those, and primarily in that setting, not because surgery is not possible from a technical perspective, but you know, if you have a 180-pound Saint Bernard who has an osteosarcoma affecting a front leg, and he's got 2 bad knees, then amputation is just really not an option for those guys. So we irradiate a lot of those. And then really, you know, soft tissue sarcomas, mast cell tumors. There are tumors of the urinary tract and of the colorectal tract that we would treat, you know, anal sac tumors. So really, I would, you know, I guess the motto we use is that, you know, if it's a tumor that you would cut out but you can't, then radiation therapy is probably a reasonable alternative. You know,
that's a really good way to think of it. I like that. You said bone cancer. You did get that in there, because I do know, because my first dog was bone cancer. Second one was nasal adenocarcinoma. My third one was mast cell tumor. So basically all the ones that my 3 have died from, I could have just taken them to PetCure Oncology. But with bone cancer, the one question I did have is, do you guys do limb sparing there as well?
We PetCure don't do limb sparing. That would be, unless it was at one of our partner facilities where we had a surgeon that wanted to and had the expertise to do it. Limb spare is definitely it's a specialty item. You know, you need
a surgical oncologist for that one as well.
You need a surgical oncologist in the mix for that. Yep.
Right. I was just curious because we do have a lot of bone dog cancer people following us, and I'm sure that would be one of their questions. But it totally makes sense that you had, it's a partnership deal, it's a combination, it's a package, basically. Right. Well, let's talk about, I know one of the other questions that pet parents have, like I have, let's just talk about some of the side effects, just generally broad strokes. We know that you can treat a whole host of different cancers with radiation therapy wonderfully and precisely. But what generally are the side effects that pet parents can anticipate, and what should they be concerned about?
Well, if we're talking specifically SRT, stereotactic radiation, the side effects do tend to be pretty limited. You know, and radiation side effects happen in the area of the radiation, not elsewhere. So we don't typically see a lot of systemic side effects in those patients. You know, really the side effects these days tend to be pretty manageable. We may still see some mild skin irritation. You know, if it's an oral tumor, we may see some oral irritation. But I think, you know, one thing that is important to keep in mind is that there is no risk-free way to treat cancer. And we know in the radiation world that you can do everything exactly perfectly. You can have your plan be beautiful. You can deliver the dose exactly where you want. And we still know that about 3 to 5% of patients, both human and veterinary, will have what we call a catastrophic outcome. You know, so they may lose, you know, not just have irritation of the skin, but they may actually have loss of the skin, things like that. And in that,
what was that? I'm sorry, what was that number again?
Did you have... you know, the reported number is 3 to 5%. Okay. When I look at our data over time, it's closer to 1%, 1.5%, 2%, somewhere in there. But when it happens, it's significant. You know, it can be quality of life changing.
Well, that was a concern with Murphy, was that could have burned a hole up into his opening to his mouth, and then you have an infection to worry about. It just those are serious complications, but as you said, those are minimal and improving over time. The more precise you are with your radiation technology, of course, then the less likely the tumor or the good tissue surrounding good tissue is going to get damaged. So it's just a function of improving the technology over time. And I was going to save this for a few minutes down the road, but it's a perfect time to talk about that, because we see now, we talked about the 3 different traditional types of cancer treatment, cancer therapy, but we're now seeing the 4th type entering into the world of canine cancer treatment, that is immunotherapy. So as we're seeing the dawn of immunotherapy and precision or personalized medicine in animal oncology, what does Neal, what does the future of radiation oncology look like? Are pet parents, or will people still be choosing radiation in 10, 20 years from now? What are your thoughts?
Well, you know, it's hard to know the answer to that question. And, you know, I became a radiation oncologist in 1987, so 1 or 2 years ago. And there have been lots of things that have come into our orbit as going to be the next big game changer. But at the same time, personalized medicine, immunotherapy is a huge part of where we're focused, you know, in humans and veterinary patients both. And it's interesting, there are some massive synergies between stereotactic doses of radiation and some different forms of immunotherapy. So I see immunotherapy, we PetCure are extremely interested in evaluating the synergies between immunotherapy and radiation. And it turns out that when you're using, so, you know, we said because you're targeting so precisely, you can really push that dose up. And what that does, it turns out that there are some very dramatic changes in the microenvironment when you irradiate a tumor with those kinds of doses. And that actually a big part of the response to stereotactic radiation is probably an immune response, that you're having local immune activation. You know, there are patients that get treated, and on the human side, it's primarily oral melanoma, or I'm sorry, cutaneous melanoma. But there are reports of patients getting treated just with stereotactic radiation for maybe an out of control primary and having their metastatic disease also go away. So we're excited. You know, we don't see immunotherapy as a competitor. We see it as an adjunct, and we're incredibly excited about some of the opportunities.
That's exciting. That really is exciting
That's
because
really
as
exciting.
yeah, it is, because as most of us know, it's not the primary tumor that gets you, it's the secondary one that takes you out. So that's very exciting. But Neal, something else I was looking into as doing due diligence for this episode is that radiation oncology is also interfacing with artificial intelligence to provide a more precise therapeutic outcome. And I'm dabbling, and we're looking at doing a clinical trial with artificial intelligence, AI as well. And I believe that's going to be instrumental. That's just so exciting, the potential that holds. So I'm a toolbox guy. In the sense, Dr. Mauldin, that I like as many tools in the toolbox as a pet parent than I can. I'm quite certain that that's true of every pet parent in the universe of pet parents. Is I want as many tools. So that's what's wonderful that you illuminated me that to think of it as in terms of a partnership, that we will be looking at treatment partnership or pairing. So that's great way to I think summarize the value proposition of radiation therapy for our pet parents, because that's something that I found that veterinarians just don't do a really good job of, that because we don't always have pet parents that choose treatment. Some of them stick with palliative care only for reasons that I guess I understand that. I certainly, there are a whole host of reasons. And in that vein, I wanted to talk to you, Ben, about adoption of radiation therapy in pet parents. What are we seeing, Ben? What are we seeing in the numbers?
Yeah, you guys were chatting about that earlier, and about 80% of the radiation therapy treatments that we do are stereotactic radiation. So by and large, that is what the pet owner is choosing when it's an appropriate treatment that is recommended and, kind of leaves their decision set. I think Neal laid out the reasons why, very well before, right? It's fewer treatments, it's fewer anesthetic events, depending on the specific situation, it's expected to be a similar outcome or even better in some situations. So it's certainly a very powerful tool. And what we find, and we found this from the beginning, is that, just like any other industry, consumers want to be educated. They want to know what their options are, more and more. And I think we saw this in human healthcare maybe a decade or so earlier. People are walking out of their offices and then doing their own searches, right? So, still by and large, the primary way that people find treatment is based on the recommendation of their veterinarian. But no doubt that in today's world, there is a lot more personal research being done and a lot more access to that research, so that people can find the information that they want and really kind of complete the picture of the whole decision set, right? Because there are a lot of modalities, there are a lot of tools in the toolbox, and we certainly feel the same way, right? We want to encourage everybody to know what all those tools are, know what all their utilities are, and then be able to customize the best decision for their family and their pet.
Yeah, I think the value proposition is very clear to pet parents. But one of the considerations, one of the factors that we haven't talked about that would be a consideration is cost. So Ben, talk to me about what is the average cost? I know that's tough because it depends on tumor type and there are so many variables. But what can typically the pet parent anticipate to spend on average for SRT or IMRT?
Yeah, so and I'm going to give you sort of the full process, because one of the things that I know people hate and we always try to prevent is, okay, it's this much for treatment, but then you also need a CT scan, right? And you also need a consult. And what we don't want to do is have somebody walk in the door thinking it's one cost and then find out there are all these, added costs that are part of it. So we try to bundle those costs and kind of lump together the consult, the CT scan, which is, critical for the treatment planning process to get the precision that we've been talking about today. And then the treatment itself, it varies market to market, but it's going to be anywhere from probably $8,000 to $14,000 for those three components. And again, depending on the part of the country you are and the nature of that market.
Yeah, that's very typical, and I think we sort of glossed over, or I did, the CT imaging aspect, or how that's such a critical part of it. Neal, can you speak to that? Because it's an essential part when you're trying to figure out where to aim the beam at the tumor. You got to know. So walk us through the CT imaging process.
Yeah, well, as you say, I mean, there have been two huge advances in radiation therapy. One is the way the collimator moves to allow us to make all these fancy shapes, and the other absolutely is imaging. And if you're doing stereotactic with a 1 millimeter margin and you miss your alignment by 0.5 centimeter, then you've made things worse, not better. So there's two major components. All veterinary patients right now treated with radiation need to have a CT scan because all of our planning platforms work on CT data. So typically we're going to do a diagnostic CT with that patient in an immobilizer. So we're going to make a patient-specific immobilizer that locks you into place. You're very reproducible and very, repositionable then. And then we'll do that diagnostic CT scan. That information all gets sent over to the planning platform. We'll generate your plan. And then that data is sent back to the actual treatment machine and back to the linear accelerator. So on treatment day, there is a CT scan mounted on the linear accelerator. It's a small version called a cone beam CT. And what we do is we acquire image of that patient. So, your nasal tumor guy would be in as a mobilizer. We would scan him with all the alignments. And then we get real time that cone beam CT, the treatment CT, and we can compare that and overlay it with that diagnostic CT. And it allows us to make very accurate, millimeter, sub-millimeter shifts to be sure we're aligned as we want to be. And then once the team is convinced that they have you aligned where you need to be, then you go beam on. And as you said, the alignment is critical, especially for a single fraction SRT. If you miss on one fraction, then that you've made things worse, not better for that patient. So we spend a huge amount of time on alignment because that is the name of the game.
Yeah, I'm only smiling because I still have Murphy's mouthpiece. I think
it's amazing how often people want the bite blocks or the
bite block. That's what you call it. Yeah, absolutely.
Yep.
I love it. I'll keep it with me till the end of my days. So, so back to you, Ben. Just kind of breaking down the numbers. I know there's really a scarcity of good data out there, but do we know where radiation therapy fits in terms of percentage of treatments compared to radiation and surgery? Do we have any of that number, that data out there?
As in radiation compared to chemotherapy? And
exactly. If you look at that like a pie chart, where does radiation therapy sort of fit into that? And and also in terms of cost comparison, because I mean, $8,000 to $14,000 was certainly a lot less than what Murphy's was, so that's reasonable. But just kind of give pet parents kind of a perspective or a context of where that fits in there.
Sure. From a pricing perspective, I would imagine that it's fairly comparable when you start getting into protocols of chemotherapy that are extensive or complex surgeries, and then the follow-up rehab and care and stuff that goes into it. So I think, frankly, all modalities of cancer care do start to get up there. And, maybe part of this conversation later on circles back to pet insurance, which is also a hot topic among pets and something that really takes one of the big stressors out of the equation for pet owners if and when they do find themselves in that situation. As far as sort of clinical breakdown of percentages, that's not something that I have an answer to. I would defer to kind of Neal's experience in the field. He may have more to add on that front.
Well, let's stick to that before we do, if we have time for it, because access, that's something that Neal spoke to early on, how critical that is. And I don't want to get, that's just a badger's nest that we're running out of time here. But I do want to lay this down on, because we're starting Hudson's Hope Fund. And for the first time, the Puppy Up Foundation is going to be paying for treatment for companion animals, for dogs, I think, is we're focusing on. And so whereas the Puppy Up Foundation has been focused on research and clinical trial side of things to date, we're going to be focused on treatment. And with treatment, we'll need diagnostics. So I certainly would love to have a conversation with I guess, Ben, with you offline about how we could maybe partner with the Hudson's Hope Fund about, in the case that we have a patient that requires radiation therapy that we can work with you guys. So certainly something to talk about, because we could have all the best tools in the toolbox. We could get all the latest, greatest, best things from human oncology, but if the pet parents can't afford it, then it doesn't really matter. So we certainly need more liquidity. We need more capital in that marketplace. And the Hudson's Hope Fund, Hudson's Hope really is that more pets can have access to the best care, and that means diagnostics too. So we're really excited about that. It's a game changer. So as we wind things down here, we've done a great job of I think bullet pointing out the value proposition of why to choose radiation therapy, and that is comparable and it's affordable. And I wanted to also follow up, Ben, with my first dog was osteosarc, and that is typically the gold standard for that is amputation plus chemo, right? So then I think that totaled 15 or 18. So $8,000 to $14,000. If you're gonna get the gold standard, which I'm that advocate, if you're gonna do cancer care, go for the gold standard. It's gonna cost, but we're looking at ways. A lot of us are working on different ways of providing capital to pet parents. So I'm a big advocate of that. Stay tuned to future episodes of Fuzzybutts and Friends about Hudson's Hope Fund. So as we wind down this episode, Neal, what would be the last sort of words that you would have for pet parents that get that first diagnosis of cancer and their beloved companion? What words would you have for them?
Well, I think the single biggest is that information is power. And probably the second is fear is crippling. So you have to find the right balance. It's hard not to be scared. As you say, our call center gets a lot of people that are just frantic because they got a phone call at 5 o'clock on a Friday afternoon. They got told a diagnosis, and now there's nobody to help them through the weekend, and they just ramp up. So there are options available today that were not available in the past. Educate yourself, or let us help educate you. Let your vet help educate you. But honestly, families that come to us after having a diagnosis are some of the best educated clients I've dealt with in my entire life. You know, that they are invested and they are taking that advocacy role very, very seriously. So I guess don't panic and learn what your options are and go from there.
I'm the panic guy. I'm both the father of my Fuzzybutts and the mother. So the mother side of me is always like, oh, that's not fair. Both of me just freaks out. I'm always scared. But now that you guys have a number that you can call, and that's something that I've never really had. Of course, I could just call and get access to a veterinary oncologist. So Ben, what is that number again? And how can pet parents find you on social media?
Yeah, 833 Pet Hero is the phone number. We try to make it as easy to remember as possible. And, again, that's what I did. And that's what I tell my friends to do. I don't know of another group of people anywhere that has the expertise that they do. These are all former oncology veterinary technicians. They're not, certified veterinarians, but they have all lived and breathed, the floor of an oncology clinic and spent their careers with those dogs and talking to those clients and interfacing from those doctors. And then, obviously for our team, they also add a level of just compassion, that is critical, right? So it's, as I don't need to tell you, every single person that calls us or a client that we get is in a really hard spot. They're emotional, they're stressed out, they're anxious, they're scared. We don't get clients that walk in cool, calm, and, just whatever. So it's a really important piece of our pet advocate team at that 833 Pet Hero number, that they are able to sort of calm and stabilize and, don't worry, we've got you. I'm going to hold your hand from here on out, and we're going to make sure that you know what questions to ask and you know who to ask them to. And it's a no cost number. There's no fee for this service. There's no expectation on the back end that you're even going to treat at a pet care center. So it's really kind of a non-judgmental, safe space. designed to advocate for the pet and the pet family.
Yeah, definitely call your GP, your veterinarian that you use. And 833 Pet Hero, that's a great first or second step for pet parents. It's a great resource. So as we wind this up, we typically end the episode of Fuzzybutts and Friends with a cancer tip from the Puppy Up Foundation. But since we've been talking about cancer the entire episode, we've felt like we would flip the switch and talk about something fun with Fuzzybutts. So Ginger, you have something special for us this week. What do you have?
I do. You know, most people's companions, cat or dog, have a special toy that they won't let go. This is Mr. Monkey, or affectionately called by Luke, the fart monkey. And my dog, as a matter of fact, if I do this, I'm sure he's going to come bugging me for it. But, you know, it's just so cute. He is so darn cute. We can't go to bed without it. If he jumps in the bed, I'm like, where's the monkey? And he's, you know, gets into a panic and has to go find it. And he's pacing until sometimes I have to find it. But I'll tell you what, if anybody out there, if you're listening, this is a orange monkey, yellow face. I can't find any more of these, and I'm so afraid that something's going to happen to Mr. Monkey. If you know where I can get these, just email me, ginger@puppyup.org, and I will get one. So
yeah,
there's my funny thing of if you can't see it, it's not quite as funny, but it is pretty.
You have to check out the YouTube channel. It's hard to describe what the fart monkey looks like, but
exactly.
Sadler, or I call him Sad Man, he's just hilarious. He loves his little fart monkey. But it is the right way, the perfect way to end this episode. I think that, guys, your companion doesn't know they have cancer, so you still have to have fun with them. So find a way to have fun for them and for yourself, because you're in for a tough ride. But that's why we have them. That's why we love them. They're our Fuzzybutts. And that's why we're here. I want to thank Neal Mauldin, the CMO with PetCure Oncology. And I want to thank Ben Chiswick. He is the marketing guy, biz dev guy with PetCure Oncology. Thank you both for being a part of Fuzzybutts this week. Thank you.
Thanks for having us.
Yeah, thanks for having us. And also just thanks for all you do. You guys have a wonderful organization that really helps support, obviously, causes that are near and dear to our hearts. And it's all part of the path forward, right? Working together to get smarter and better at how we treat cancer in pets and people every year.
Thank you, Ben.
Yes.
Thank you. The Puppy Up Foundation, we've done a lot of good work, but we're just getting started. We have a lot of great big things in store. So thank you very much. And thank you to the audience for joining us this week of Fuzzybutts and Friends. Puppy Up. Talk soon.